Good morning. I think it's still morning. My name's Courtney Harkness and I'm a radiation therapist at Gippsland Radiation Oncology. It's run by Alfred Health and we're located about 2 hours east of Melbourne. I've worked there for about 9 years or so. Today I'm going to discuss our experiences with deep inspiration breath hold using the AlignRT SGRT system, focusing specifically on how and why we went about implementing a process that enabled us to do online couch corrections based on imaging. So just a bit of a background. We implemented AlignRT at GRO in September 2017. Around 3 months later, we started treating our first DIBH patients. We were lucky enough that our other site based at the Alfred Hospital had been doing both AlignRT and DIBH for a number of years, so they were really helpful and vital while we were implementing this process as a support and training, and it was great to gain their experience as well. Around 6 months after we implemented DIBH, we decided to look at how our current process was going and if there was any ways that we thought it could be improved. But before I get into that too much, I'll talk about what our initial process was and why we thought it could do with some improvement. So I believe our in-room DIBH process is the same way that it's used in a lot of centres. It seems similar to how other people have talked about it today. Patients have both a free breathe and a breath hold scan at CT, and we use both of those scans when they come for treatment by using the body contour exported from our planning system. So the patient is positioned using their free breathe scan with the patient breathing normally. Then once everything is aligned on AlignRT, we switch over to our DIBH plan, and then obviously they're going to be out of tolerance once we switch over until we get them to take their breath in, and all the deltas will shift. As their chest moves up, all the deltas will become within tolerance. So once we've confirmed their acceptable breathing technique and we're happy that they're all lined up correctly, we'll leave the room, and through the microphone we'll instruct the patient to take a breath in and hold. And once everything's within tolerance, within all the thresholds, we'll take a KV image and then we'll repeat it for a paired KV image. For our original treatment process, we had an online image match tolerance of 0.3 centimetres. If the image match was within 0.3 centimetres, we would go ahead and treating all our fields while the patient's in breath hold, breathing in between each field, of course. If the image was out by greater than 0.3, there's a couple of things we'd have to do. So first we'd switch back to the free breathe surface and just check whether perhaps the patient had actually physically moved off where we'd set them up to. So if they had moved, we'll adjust their position or the bed to get them lined up correctly again. Alternatively, if they're still lined up where they're supposed to be, we didn't have many other options except to attempt to reposition the patient or reset them up, and then retake our images to try and get them within the 0.3 centimetres. So as you know, AlignRT matches to the external surface of the body, while with our breast and chest wall treatments, we actually mainly focus on matching to the chest wall and the superclav anatomy, using the breast contour as a guide. This means that a small change to the contour or the daily position, including a difference in arm position, can affect our online image match results. And that meant that we quite often had image match results that were beyond our tolerances of 0.3 centimetres. meaning that we had to reset up a lot of patients, causing knock-on effects such as an increase in treatment times and staff or patient stress. This back and forth of having to reset up patients was only necessary because we had no actual process that enabled us to do an online shift using our workflow. So the difficulty with doing an online shift with the DIBH was that because we already had the patient set up so that everything was in tolerance on AlignRT, once we shift the bed to correct the image, we also had to update that target surface for when they take their breath hold in to reflect that we'd shifted the couch. Or else when they would take the next breath in, it would be out of tolerance unless we had updated that surface. So we decided we wanted to establish a process for online shifts. Our main motivations was the potential to decrease the online imaging action thresholds to bring DIBH in line with all our other techniques. So we were using the 0.3 online tolerances for DIBH. However, with all our other treatment techniques, we actually do daily KV imaging and shift everything to 0. So we hope to be able to bring DIBH in line with all our other techniques. We thought it could then decrease the DIBH treatment times because of less setups, increase our accuracy, improve the reproducibility of breath holds within each fraction because you're actually re-zeroing after all your image match, and decrease stress for both patients and staff. So it was around the time that we were looking at this process that one of our radiation oncologists attended an ESTRO conference in Switzerland, and she came home with information about a process presented by the University Hospital of Zurich that involved online shifts being performed using AlignRT for DIBH. She was very enthusiastic about it, and we developed our process based on what they were doing. So the in-room setup process was the same as previously. We'd then take our KV paired images in breath hold, match the images. We would then get the patient to re-enter breath hold, apply our couch corrections while they're still maintaining that breath hold, and then quickly take a new reference capture on AlignRT, which becomes our new target breath hold surface. AlignRT would then re-zero everything, so the next time they take their breath in, even though we've shifted the bed, it will all line up with the right amount. So the whole process would take a couple of seconds, and we would treat the patients in breath hold like previously. So it's worth noting that we send through both the heart contour and the body contour as structures to use with imaging. We send them over from Eclipse. And this helps us to ensure the heart position during the breath holds is consistent with what is planned. So we can usually see the heart pretty well on our KV imaging. And we try to maintain the relationship between the heart, the chest wall and the body surface, meaning that we're not changing the actual amount of breath the patient's taking. We also take daily in-field EPI images on our medial and super club fields. And if breath hold's not maintained during this shift, the couch can actually be reverted back to the pre-imaging position. On our true beam, you can just open the image match and select reset shift. That'll enable you to shift the couch back to where it was, and you can use the previous surface again. So after using the new process for a while, we retrospectively assessed all of our previously treated patients, and we compared both of our methods. So we had 247 tangent fractions and an extra 136 fractions that included the superclub, and they were treated with our original process with no method of online couch corrections. Using our new trial method that enabled the couch corrections, we had 253 fractions treated with tangents only and a further 47 fractions that included superclav. So some of the data that we assessed included the number of image sets taken on the fractions, the total number of setups per fractions, the number of times the pre-treatment imaging exceeded our tolerances, the time between initial KV images and the final beam-off time, and also our mismatch results on our during in-field EPI images. So I'll talk about some of our notable results. Treatment times for our tangents-only treatments decreased from an average of 9.37 minutes to 8.35 minutes, which, as I said before, was measured from the first image capture to the final beam off, so it didn't include setup time. For treatments that treated both tangents and superclav, the average treatment times decreased from 18.1 minutes to 13.6 minutes. You can see on the pie chart there that the percent of fractions taking over 20 minutes to treat decreased from 37% down to 8% with the new method. You can see that with our new method, no treatments took over 35 minutes compared to 8% of them on our previous way. You can see the number of times the patient was set up reduced, with only 3% of treatments needing to be set up a second time using the new online shift method. Treatment accuracy. This, for the tangents alone, treatments that was measured on the medial EPI field, and this was matched independently retrospectively. Originally, we had 37% of fractions where our EPI image mismatch was out by more than 3 millimetres when assessed offline, and this decreased to 5% once we could do online shifts. For treatments with superclavs, this was measured on the superclav EPI in-field image that was captured during treatment. The percent of fractions that had image mismatches of greater than 3 millimetres decreased from 57% to 0%, which was a big improvement. Our data helped us become more confident that our change in treatment process improved the accuracy of the treatment field delivery, reduced the need to perform multiple setups, decreased our average treatment times, particularly for superclav patients, and decreased the total number of images taken on patients. It also allowed us to streamline our verification imaging policy to bring it in line with all our other techniques. So if you're in a department that doesn't do daily before imaging, or you don't have such tight tolerances, then the standard DIBH process works fine. We've started to use AlignRT and DIBH with some more complex treatments, such as VMAT and IMRT, treating chest walls, including nodes such as IMCs. So for cases like these, we really like the ability to have a bit more accuracy, and we like that it's made our treatments much more efficient and easier for everyone involved. Just some acknowledgements to Dominic Davis for all his data collection and hard work, and Dr. Louise Nardoni and my other colleagues at Gippsland Radiation Oncology.